So I did my presentation on scapular winging. Scapular winging sometimes is also called winged scapula. It's a condition that affects the shoulder blades. Shoulder blades usually rest flat against the back of the chest wall. Scapular winging occurs when the shoulder blade sticks out, like you can see in the photos. While this condition is rare, it's usually painful and makes day-to-day activities as lifting grocery bags or brushing your teeth very difficult. The term winged scapula is used when the muscles of the scapula are too weak or paralyzed, resulting in a limited ability to stabilize the scapula. As a result, the medial border of the scapula protrudes like wings. The main reason for this condition is either muscular or neurological. So you can see in picture C that medial border of the scapula is protruding pretty bad. Anatomy: the scapular winging is typically caused by the damage of these three sections of the posterior triangle. So the long thoracic nerve that innervates the serratus anterior in photo 1, and then the dorsal scapular nerve that innervates the rhomboid muscles in photo 2, and then the spinal accessory nerve that innervates the trapezius in photo 3. And then other muscles that can be affected are the levator scapula, the pec minor, and the lats, and then other nerves are the accessory nerves, and then the long thoracic and the brachial plexus itself. Neurological or musculoskeletal can be clinical presentations, the neurological on top and then the muscle on the bottom. So neurological can sometimes protrude a little bit more than muscular entities. Pathology: scapular winging refers to the condition of the scapula itself. The winging occurs post-injury or occurrence in one's life. An injury or condition is found. Scapular winging tends to settle in the displacement of the scapula in the dorsal triangle. It is evident or obvious visual deformities are when the vertebral or inferior angle of the scapula displays unusual prominence. With a misplaced scapula, the body will suffer from a limited range of motion and decrease in shoulder strength. Along with motion complications, patients will also experience discomfort with everyday activities. There's 3 different types of a mechanism of injury for scapular winging. So non-traumatic, meaning that there's no physical force that's applied. These can occur anywhere from a drug overdose to medical conditions like muscular dystrophy. And then repetitive motion overuse injuries. This is where you're going to see with overhead athletes, endurance athletes, or someone that might dig or trim hedges for a living. And then traumatic injuries itself, so a blunt trauma to the body of your neck, upper back, or shoulder itself. Signs and symptoms. So signs and symptoms of scapular winging can differ from patient to patient. These 2 elements are dependent on the underlying cause or mechanism of injury and then the muscles and nerves that are involved in that injury. Most commonly, it's unilateral rather than bilateral with the shoulder blade protrusion. In scapular winging, it is more neurological and primarily caused by nerve damage. There will be weakness in the muscles of the neck, shoulders, and/or arms. This is making lifting, pulling, or pushing movements difficult to do. Other symptoms may be pain or discomfort in neck, shoulders, back, extreme fatigue, or a drooping shoulder in a deformity standpoint. Characteristics: so there's 3 types of muscular scapular winging, and then there's 2 types of neurological scapular winging. So the first muscle type would be a visible inferior, pronounced anterior tilt of the scapula. This can be from a shortened pec minor or a shortened joint capsule, and then a muscular imbalance of the trap in the serratus anterior. Type 2 can be a medial and internal rotation of the scap. This can be a shortening of the posterior capsule, and then shortening of the lat, and then an imbalance of the trapezius and serratus anterior. Type 3 is a inferior and downward rotation of the scap, and the 3 are shortening of the levator and then an imbalance of the trapezius. Neurological would be a separation of the scapula from the thorax, an elevation of the scap, and then the medial angle would be closer to the spine, and then this is a damage to the long thoracic nerve, and then an insufficient serratus anterior. Type 2 neurologically is going to be the same with separated scapula of the thorax, but it's going to have a lowering scapula, and then the medial line is going to be pulling away from the spine. And again, this is a damage to the accessory nerves, and then an insufficient trapezius. Special tests. Although there are no special tests, there's some active movements to assess whether or not they suffer from scapular winging. So in the photograph, you see someone doing a wall push-up. So the examiner would be looking for scapular winging as they're in full range of motion of that. Asymmetric movements of both scapulas especially. And then another test would be putting the serratus anterior under maximum resistance, thus forcing the scapula to wing if the condition is present. Positive findings when completing a push-up exam. So this is just saying that if you see that medial winging, it's going to look towards the serratus anterior long thoracic nerve lesion, and then if it's lateral winging, you're going to see a trapezius lesion. Predisposing factors, there are none, but overhead athletes, obviously, and then anyone working with a lot of overhead movement is going to be at risk. Management and treatment, depending on which nerve and muscle are causing the winging, that's where the treatment is going to come into play, so non-surgical or surgical. Starting with non-surgical, these cases are caused by damage to the serratus anterior long thoracic nerve, can heal on their own, but it can take about 2 years to be fully functional, so a brace or physical therapy might be recommended to help that healing process. Another surgical case would be damage to the dorsal scapular nerve, in which physical therapy, massage therapy, medication, and braces can all be combined to help these. And then if non-surgical treatments no longer show improvement, physicians may suggest surgery. One brace, known as the Winger's brace, can help with serratus anterior or trapeze muscles injuries. So this brace itself is designed to press the scapula up against the posterior thoracic wall, thus preventing stretching of the injured muscle and providing limited functional movement. Surgical, most surgical treatments for scapular winging are results of a traumatic injury or an injury to the spinal accessory nerve. So most treatments are nerve and muscle transfers in which a nerve and muscle or both is moved to another part of the body. Focus is mainly shoulder, back and chest. So there's some pictures what they would do for a medial and then what they would do for a lateral. Another surgical is static stabilization, where a sling is used to attach the scapula to either the ribs or the spinous process. This is a risky surgery as the sling can stretch out over time, and then another surgery would be needed to correct that. And then a third surgical option is known as a scapulothoracic fusion, which is noted in the photo. And this is very risky because this is where the scapula is connected to the ribs completely, and when it's being connected, it can cause permanent bone fractures, and it can be post-surgery, the patient may not be able to lift their arms. Management and treatment, a specific surgery that is well known to fix scapular winging is known as the Eden-Lang procedure, in which the transfer of the levator scap tendon is to the acromion, and then the attachment of the rhomboids to the central portion of the scapula within that infraspinatus fossa. This is commonly used to fix the trapezius scapular winging issue. Patients report a lot of pain relief and then complete shoulder function post-surgery. Home exercises and home management is also an opportunity that physicians may give people that are suffering from scapular winging. So some of these might be stretching or range of motion or strength standpoint, but this can cause the scapular winging to get worse. The photo is of a lady doing part of a Blackburn series to do some strengthening and range of motion. Referral and immobilization. So after reporting symptoms and concerns to a physician, special tests can be performed to confirm the diagnosis with scapular winging, and then electromyography may be used to take a closer look at the serratus anterior, the trapeze, and the rhomboid muscles to see any alterations along with those muscles, which is photographed in the picture on the left side of the slide. Prevention. There's not a long list, but there is a couple things that people can be concerned with when preventing scapular winging. Some of those may be avoiding repetitive shoulder arm movements, maintaining a correct posture, using a special chair or pillow, using shoulder-friendly bags and backpacks, avoiding carrying way too much weight on the shoulders, and then stretching and strengthening the muscles in the neck, back, and your shoulders and upper arms. And then in the picture, it's showing a correct sitting posture. This is important for people that have desk jobs. There's multiple ways to perform Mulligan, in which can provide relief from patients suffering from scapular winging. So those could be first rib mobility, glenohumeral joint mobility, acromion-clavicular joint mobility, sternoclavicular joint mobility. Then all these can help surrounding joints and muscles to create pain relief, and then increased range of motion when suffering from scapular winging. And then there's a video to show a good representation of scapular mobilizations itself, and then the link on the left side of the screen in between the title and the photo is a PowerPoint about Mulligan. For my PCOT, I chose a case in which there's a 24-year-old man, electrician, and his hobbies were swimming and cycling, so an endurance athlete on top of a heavy arm movement job. He presented with scapular wing on his right side. Intervention is including massage, exercise, stability, strength, speed, and coordination into his everyday life for 6 weeks, comparing to what he had been doing before, which was nothing. And the outcome was pain reduction and ability to increase shoulder load when doing exercises. And then on this next screen, so this is from my PCOT, but this is his before and after pictures after those 6 weeks of the combination of movements and whatnot. So then here are my references.